It is Dr. Cruz's idea, after conversing with Dr. Murray, to proceed with the balloon pump for the two reasons that I just cited. Number one, Dr. Murray found a pulse. Number two, Dr. Murray requested that UCLA did not give up easily and try to save his life.
Okay, now, you used the term good faith a little while ago. Is good faith a medical diagnosis?
Not to my knowledge.
Is it an indication for treatment?
No.
I mean, there was absolutely no reason whatsoever to do a balloon pump, was there?
There was no indication if there's no pulse. If there's a suspicion that there can still be a pulse, then there's still, the indication still exists.
And when you've got, what time did you do this balloon pump?
I could not remember. Could you go back to the record and remind me? But it was maybe, if I have to guess,
well, don't guess. You can estimate, or else you can go to the next step.
This is my estimate. 5-7 minutes. As soon as we got the equipment, we put it in. I think that it's 5 or 7 minutes.
When
That's
did you
my
get
guess.
the equipment?
Our CCU charge nurse brought it down.
Okay, when did that happen?
Right away. After the...
what time?
5 or 7 minutes is my guess. I don't have the record in front of me.
So what? The only time you really know about is 1:35.
1:35 was when I started talking to Dr. Murray.
Because at that point in time, you looked at your pager.
That's correct.
And other than that, you don't know any times.
No.
Just a moment, please. Sustained. It's argumentative as well. The answer is stricken disregard. Re-ask.
Do you know any other times other than the 1:35?
I could give you an estimate of time interval as to when we put in the balloon pump, and there was a time of death that we called.
When did you put in the balloon pump?
About 5 or 7 minutes after the agreement to put in the balloon pump was reached.
What agreement?
The agreement with Dr. Murray, Dr. Cruz, and I, that we're going to proceed with putting in the balloon pump in a desperate attempt, even though very much futile, to try to bring back Mr. Jackson to life. If this should fail, we would call it quit and call it death, time of death.
Okay, now, did Dr. Murray participate in this agreement?
The agreement was made with Dr. Murray, so Dr. Murray participated in the agreement, and he kept his word. And when the procedure showed to not be able to reach its desired miraculous effect of bringing him back to life, everybody agreed to call the time of death, including Dr. Murray.
Okay, now, so prior to putting in the balloon pump, you went to Dr. Murray and asked him if he'd agree that there'd be no more procedures if you used the balloon pump and it didn't work?
Yes. The agreement was made very clear, not only just to Dr. Murray, but to all the personnel present in the ER room at the time.
Okay, and who posed this agreement?
Could you repeat the question?
Who put forth the terms of this agreement?
The CCU team, and that means Dr. Cruz and I.
And so basically what you said to Dr. Murray is, hey, look, we're going to try this procedure. It probably won't work. But if we do that, that's it. We're going to call it.
If we do that and it fails, then we need to call it stop.
Okay.
Yeah.
Now, what did Dr. Murray say in response to that?
He agreed to it. Yes.
When you say he agreed to it, what were his words?
He said yes. The word is yes.
Okay. So you told him what the conditions were, and he said yes.
Yes.
But the balloon pump wasn't his idea at all.
No.
If I could have just a minute, Your Honor.
You may.
And after talking with Dr. Murray. You went back and talked to Dr. Cooper. Did she then tell you the other drugs that Dr. Murray told her about?
I did not ask Dr. Cooper as to other drugs being involved or not.
Okay.
That was one thing that I omitted.
Now,
I did ask Dr. Murray in my earlier conversation whether he attempted to use anything to reverse the effect of Ativan.
what would be appropriate to reverse the effects of Ativan?
Flumazenil.
How much?
Just give low, 1 milligram or something like that, and started
The insert calls for 0.2 milligrams, doesn't it?
0.2 milligrams, yes.
So that would be the appropriate dose to give.
Yes, it is more the time. The purpose of using that was as soon as the patient was down from Ativan, to use that to prevent the further depression of the brain state,
How fast?
to
Excuse me.
prevent or delay the need to put the patient on the ventilator.
So how fast after the patient stops breathing should it be used?
Immediately. We're
Okay.
talking about seconds. Immediately.
What is your window there? Would a minute later
Seconds.
be too late?
Before the placement of the patient on the ventilator, the hope is to delay, to buy time, to get the equipment ready to intubate the patient.
So if a doctor feels that the patient is suffering from the effects of Ativan, lorazepam, the appropriate procedure would be to IV inject 0.2 milligrams of flumazenil.
Yes, you can
And
repeat the dose if it didn't work, but it has to be fast. The point is to try to reverse it in order to delay or not having to go to the need of intubating the patient.
And how long? I've heard your previous testimony talk about window of opportunity. You know, time is of the essence.
Yes, sir.
How long, from when the patient has a complication from lorazepam, how long does that window of opportunity last where you can achieve something by injecting 2 milligrams of flumazenil?
2 or 0.2?
Well, 0.2, excuse me. Thank you, Your Honor.
You're welcome.
We're talking about seconds to minutes, and the reason why I said time is critical, time is the essence, is because it means a drastic difference between 100% chance of recovery with minimal neurological impairment, meaning we could totally reverse this, especially when the patient has never been diagnosed with any chronic illnesses of the lungs, the heart, or the liver, or the kidneys. It is totally reversible, 100% chance reversible. Get back to life at baseline with minimal impairments to 0% of recovery. But Ativan, as I said, did not typically do that. They do that sort of effect, causing severe respiratory collapse. It does not cause cardiovascular collapse. It can cause the patient not to stop breathing because it depressed the brain state so much that it could do that.
So my question was, I asked you, how long is the window of opportunity where flumazenil
Seconds.
will be a good solution?
As soon as we found the patient down and we know that the patient has Ativan on board, and that's when we use it. Use it right away. As with any narcotics or sedatives that we use, if that sedative has an antidote, the antidote has to be available at hand for immediate usage.
I know. You want to use it right away.
Yes.
My question is, how long is the window of opportunity where there is a good chance at success using it?
Minutes. Seconds to minutes.
Okay. Give me a number of seconds to a number of minutes.
It depends on the dose and how it was given. If you gave Ativan 20 milligram IV, as you mentioned earlier, that window of opportunity was very small for you, and 0.2 milligram of flumazenil is probably not going to cut it.
Okay. I'm asking you, not small or large or minutes to seconds. I'm asking you precisely from a point in time. What is the range? What is the window of opportunity where it would be successful?
After you administer flumazenil, how do you going to tell that it is successful? Am I understanding you?
After you've detected that the Ativan or the lorazepam
Yeah.
has caused a problem, and the patient, say, ceases to breathe, how long is that window of opportunity where you could successfully use flumazenil?
Minutes, sir.
How many?
2, 3 minutes.
Okay, after 2 or 3 minutes, the window of opportunity ceases and you can no longer achieve a desired result with flumazenil.
Correct. Probably the next step or the concurrent step is to get anesthesia, to get ready to intubate the patient.
Okay, but after 2 or 3 minutes, you're not going to, flumazenil is just not going to work.
It's not that it's not going to work, but you are wasting time instead of preparing for the next step.
Oh, so if you don't get the flumazenil in within 2 to 3 minutes,
Yes,
the next step is to intubate.
because the patient is progressing to respiratory depression now and would need breathing support, being put on a ventilator, things like that, and that would require assistance from the anesthesia staff. So if 2-3 minutes pass by and flumazenil was still not around there, concurrently, actually, when we ordered flumazenil to be brought by the nurse or assistants, we had to get anesthesia to be on board with us. So if flumazenil came on time and achieved the desired effect, we may not need to intubate if the patient already woke up. If not, we would have to proceed very soon. So it was just minutes that we're talking about.
Am I correct in assuming that with 4 milligrams of Ativan, you wouldn't expect to have an event that required flumazenil, would you?
Not really, especially for a patient that has been so used to taking it. Now, if you use it on a really small, frail, petite lady for the first time, she's never been exposed to it, you may see that, but not in a person that has been accustomed to that sort of dose, because his drug tolerance would be a little bit higher.
So a person that's somewhat tolerant to benzodiazepines, 4 milligrams of Ativan, you don't expect any complications, do you?
Overruled. Do you understand the question?
Could you repeat the question again?
So if you have a person that's somewhat tolerant to benzodiazepines, has been using them over a period of years, you wouldn't expect 4 milligrams of Ativan to cause a problem like that would require flumazenil, would you?
No. Let me clarify the question, because from what I hear the question, it looks like there is 2 stems to it. Would I expect a problem from 4 milligram Ativan IV? By problem, I assume that you say cardiovascular collapse and respiratory collapse. As I mentioned earlier, Ativan shouldn't cause cardiovascular collapse. It can cause patients to stop breathing, however, especially with large dose. Now, would it require flumazenil? If you see the patient is down and Ativan is the only thing, or all the benzodiazepine is the only thing on board, use it. What do you lose? Use it while you're buying time to get the patient to be ready for intubation. But 4 milligram IV Ativan, we could use that for procedure, and I've never seen that we had to go to the need of using flumazenil to wake the patient back up or having to intubate the patient after just 4 milligram of IV, even though it is a moderate dose. It is not a large dose.
If I could just ask you